These are the goals and objectives of what we're going to talk about today. I'll let you read them. The areas from a competency perspective that we're going to cover. And I have no disclaimers. I've gotten absolutely no economic benefit, but again, I will disclaim that you guys have been extraordinary, hospitable, and thank you. We're going to take 2 little quizzes before we actually really jump into the information. If you were to look at these 3 communities, which of the 3 would you believe would delay or not seek care at all, knowing that they have a medical issue, most common, least common, and which in the middle? Any thoughts? We wouldn't be talking about LGBT, would we, if I... So I want to really start with a very unknown fact, and quite honestly, that the LGBTQI community actually has significant healthcare disparities. And I'm really talking more on the adult side than the pediatric side, but it's really not something that's in our psyche, that there's significant healthcare outcome differences amongst the communities. That is different than their heterosexual brothers and sisters. What, I have to be honest with you, I tricked you a little bit, because if I would have put LGBT peoples of color, they definitely would have been significantly higher than their Caucasian brothers and sisters from a not seeking care, delaying care, and worse healthcare outcomes. So the point of this slide is really to kind of have a conversation about the fact that it's extraordinarily important to talk about disparities amongst different groups, but to be conscious of the fact that when you do that, you also pose a significant risk of stigmatizing those same groups that you're actually trying to help. So I want to be very conscious in saying that that is not my goal in having this conversation. And also saying that there is no gene, the LGBTQI community does not have a gene that inherently makes them sicker or any of the healthcare outcomes that we're going to talk about. Really honestly, all the healthcare outcomes that we're going to talk about are a byproduct of society and the community's maladaptive response to society. Although we love to put ourselves in a box, we're actually extraordinarily complicated. Most, and I'm not talking about people who are intersex, are born and we identify them as male or female from a biological perspective, which may or may not coincide with how they self-identify from a gender perspective. Having said that, a lot of my transgender patients are not necessarily trying to be what we would call the typical male or typical female. So even then, when we look at their gender identity, it actually can be somewhat fluid in between, even though it does not correlate with the biological sex assigned at birth. Aesthetically, how one chooses to present themselves to society may or may not correlate at all with one's biological sex. And again, a topic that's not talked about very much when you're talking about LGBT actually being bullied by society. Unfortunately, there's also a group of society that actually is straight, but because of their appearance, we make inappropriate assumptions and treat them as if they were gay, lesbian, or queer. Sexual orientation, again, is not necessarily in any way does it reflect behavior. And as a physician, this is something extremely important to understand. How you identify your orientation, which is heterosexual, LGBT, and I'm going to use queer a lot, as an umbrella term that youth use, may or may not reflect your behaviors. And just as example, I don't know if any of you guys are familiar with the term on the down low. well discussed in the African American community. But in doing this work, I assure you all communities have men on the down low. And what that actually means is that they fully and only identify as heterosexual. They don't even identify as bisexual and absolutely do not identify as gay under any circumstances. But their sexual partners, actually, majority may be same-sex partners. In their mind, the sexual act is purely a physical release, a physical act. There is no psychological connection. There is no affinity whatsoever. And so if you were to simply ask them, are you straight, gay, bisexual, they would say without hesitation, I am straight. And they are not lying to you from their perspective. And if your goal was to determine if you have risk factors you need to discuss, you both would have missed the boat completely. So again, we are extraordinarily complex when it comes to this issue. Trying to make this really neat in a little square box may not and probably will not get you to where you want to get if the goal is risk reduction. Another little quiz. Hopefully you've woken up and you'll speak up a little bit more. I put before you, and it's going to be 2 slides. Which of these would you say, and we're talking high school students, 9th through 12th grade, which are more common amongst heterosexual high school students? Which are more common amongst LGBT high school students? Transgenders are not part of this study. Any thoughts? Heterosexual? Mm-hmm. So the person who said all of them is correct. Now really think about this. Think about this in terms of mental health, physical health, and socioeconomic determinants for the rest of their life. These have significant implications from a mental health, a physical health, and social determinants of health for the rest of their life. And these are behaviors that they're having while they're your patients. I'll ask you a question you don't have to answer. How many of you screen your patients that are LGBT for these behaviors? What? 1 hand, 2 hands. Thank you. At least in the school setting, part of the social fabric that actually probably leads to maladaptive behaviors are these. Let's move on to how we might play a role. So there was a study done. It was done in the Carolinas, looked at almost 400 patients, just so we won't say, oh my God, these are probably old prehistoric physicians. The average physician is 41 years old. Average physician is 41 years old. The actual study was really, I should say the primary question, obviously there's a secondary question. The primary question was teaching pediatricians how to discuss being overweight / obese and some strategies on how to deal with that with their patients. This was supposed to happen at the annual, and at least in this setting, an annual meant kind of a comprehensive. And so the secondary part of the study that the physicians weren't aware of, probably, was how many actually take a sexual history, talk about dating, talk about sexual identity, and what language do we use in asking those questions. So that is the part of the study that I'm actually going to talk to you about. We're not going to talk about the obesity part of the study. So, inclusive language, as you can see, basically is what we learned in medical school. Open-ended, you don't define the pronouns, you allow the patient to define the pronouns. They define direct, non-inclusive as you are defining the pronoun. You have a young lady in front of you and you very clearly say, do you have a boyfriend yet? Indirect, non-inclusive, I think will be offensive, could potentially be offensive to everybody, no matter what you're, if you're gay or straight. But to give you an example, the point here is, and I always tell my teens, if someone is going to have sex before marriage, they should always, 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 and all of these are direct quotes from the study, use condoms and birth control. If you identify as lesbian and only have sex with women, is that relevant? I'll let you answer that. The results. I have to commend you. 63% of you at least broached the subject. I can say without question, my colleagues who are internal medicine adult doctors, there is no way on earth they would have been 63%. I would be lucky to see a third actually would have broached the subject. So you are more comfortable with broaching the subject. What I will say we probably have room for improvement is less than 4% used inclusive language. Almost half use very blatantly heterosexual sort of vantage point to ask the questions, and almost half used non-direct. What I will say about this is that, as we learned in medical school, if you really want an honest answer to the question, you can't tell the patient what you believe or he or she believes they want you want to hear. And very clearly, this study and others clearly say that when we are taking a history amongst youth, we make it very clear to them what the acceptable answer is. And if the goal, once again, is to identify which of our patients identify as or at least questioning themselves as being LGBT, so we can step back again to all those risks that we just talked about and start talking about which of them they're at risk for, then we need to have a conversation where they feel comfortable giving us an honest answer. And so I think there's lots of room for self-reflection and thought around how might we do this a little bit better. Also, and I'm going to get to it at some point, but if you have patients who do identify as being LGBT, especially the transgender, really honestly in the back of your mind be thinking about, do I need to screen more than usual for these? Because the risk is very high, especially amongst the transgender. The next study that I'm going to talk about is there any long-term effects? I hear all the time, life will get better. Be resilient. If you can just get past these years, kind of teenage years, and actually kind of get out the house and get on your own, you'll be just fine. Is that true? The Family Acceptance Program, and if you're interested in this, I would strongly encourage you to look it up. Caitlin Ryan did it, and I'm going to show you acceptance. There's also a second part of family rejection, very much the same study as I'm setting up. It was the same study, they just were smart enough to get more than one publication. They looked at adults, they were 21 to 25, self-identified as LGBT in the Latino, Caucasian or mixed Latino community. They did not look at, and when I talked to her, I still don't understand why they did not look at people who identify as being Black spectrum or Asian spectrum at all. So that is a definite limitation. There are 55 open-ended questions. Again, when they ask the question, they're 21 to 25. The patient is reflecting back when they were a teenager. These are examples of the 55 questions, just to give you some idea, and they scored it from my parent never, ever, talked openly about my sexual orientation. 2 or 3 all the time, was a routine thing. The second part of the same study, the questions were around mental health, drug abuse, being in abusive relationships, risk factors from a sexual perspective, including HIV, et cetera, et cetera. What did they find? Again, they're asking about their childhood or their teenagehood, and now, is there any correlation with being a young adult? They broke it up into 3 groups. If your family pretty much said, we want to have nothing to do with you being gay or your gay friends, low range. If it was sort of, family cool about it, high range scores. I know this is very small, but if you look at, and they use real tools to screen, as a 21 to 25-year-old, self-esteem, depression scales, substance abuse in the last 5 years, sexual behavior risk, suicide thoughts, suicide attempts. Every single one of them is statistically significant except sexual behavior risk, and we'll get back to that. So the less accepting, or let me take that, the more accepting your family was of your sexual orientation as a teenager, the less likely you have issues with all of these. And every single one except sexual behavior is statistically significant. If you, though, were to look at this from the count, and I'm only just doing the acceptance, if you looked at the rejection and you pulled out the men, the more your family rejected you around your sexuality as a teenager, I'm talking about men, the much, much more likely you are to have high-risk sex, and much more likely that you are actually HIV positive between the ages of 21 and 25. So this concept of just bear it, life is going to get better, is not inherently true. And so and again, I know this is a very complicated topic, but in having these conversations with the patient and the family, if you have the ability to interject into this conversation that they're letting the child know about their disapproval or their lack of acceptance has potential lifelong consequences for their child. And they're doing this out of love. When you look at the study and you ask the parents, well, why did you say that? It's not a single one said, I hate my child. Everyone pretty much loves their child. They just want the best for their child. What they don't realize is saying, oh, being gay is not the best. What they don't realize is telling them that you don't want them to be gay is really not the best from a long-term health perspective. Case 1, and actually we're only going to do one case. I'm going to focus on gay men, in all honesty. Not that my lesbian sisters aren't important, but in all honesty, there's very little literature that I can find around behaviors when they're teenagers that really lead to negative outcomes as adults, in all honesty. But we'll walk through this. So, you have a queer kid in front of you. You have a heterosexual kid in the next room. Is there anything that you need to do different between the two? Are they basically the same child? Or is there something, honestly, that you should be doing in addition or different for your queer patients? STD screening. Almost all of us, when we do STD screening, we tell someone to go pee in a cup and drop it off at the lab. Gonorrhea and chlamydia, sufficient most of the time. The gay community the majority of syphilis is in the gay community. And if that's all you're doing is having someone pee in a cup and drop it off at the lab, you will never screen for syphilis. And I assure you, you will miss syphilis in this community. Because at least in California, the overwhelming majority is in gay men. Also, you will have more false negatives for gonorrhea and chlamydia if that's all you're having them to do is pee in a cup and if their sexual behavior is anal receptive. You will drastically increase your chances of actually picking up anal gonorrhea or chlamydia if you do a swab back there than having them pee in a cup. Hepatitis. We know to vaccinate all of our patients against hepatitis A. The CDC recommends for gay men B. We know all to vaccinate against hepatitis B. The CDC recommends for all men having sex with men that you also vaccinate against hepatitis A. HIV. Whether you realize it or not, the actual real frontier of HIV is youth. The overwhelming majority, and I have it on the next, a little bit more in depth on the next slide. Matter of fact, why don't we just jump there? About 50% of all new cases are between the ages of about 13 to 24. I'm talking about all new cases in the country are between the ages of 13 and 24. 50% of this group are unaware that they're HIV positive. So from a public health perspective, they are at high risk of transmitting to others. Make up 17% make 17% of the population, 26%, of the new infections are this group. What I said earlier is correct, though, and it's an intersection between being African American in this country and being gay in this country. 50% of all of these new infections are African American youth, as you can see here. This is getting worse. The percentage that is this age, they're getting HIV, is getting higher and higher. It's not plateauing. This is actually growing the fastest, are young people actually getting HIV. This screen I just wanted to show on purpose, just because if you were to look at it, you would say, well, most of them are really between the ages of 20 and 24. Well, most of them are between the ages of 20 and 24 when they're diagnosed. Most people who are HIV positive are positive for a couple of years before they're actually diagnosed. So really, honestly, we are not capturing a significant number, I assure you, who are actually positive at 15 to 16 because we're not screening them. And this is just giving you absolute numbers. Pre-exposure prophylaxis. So this is the only FDA-approved prevention of HIV. So again, something to at least think about if you have a gay, especially if they've identified themselves as anal receptive and not using condoms and sort of a different person every week. Something to think about. Truvada is actually an HIV medication, but it has been found actually to prevent the spread of HIV. If a person takes the medication for a week prior to the exposure to HIV, takes it every day, there are almost no reports of actually becoming HIV positive, and I don't care what you're doing, from if anal sex. Unfortunately, it does not cover vaginal cervical tissue nearly as well. But for anal sex, if the person swallows the pill, it is almost guaranteed that you can prevent transmission of HIV. So again, something to think about. I know as pediatricians, you probably don't think in these terms, but HIV is for life. And I assure you a significant number of patients who are in that 13 to 24 age range, they're becoming HIV positive, actually got the disease before they left your clinics. the CDC has a whole lot, they being the CDC, you know, men have sex with men criteria, heterosexual criteria, IV drug use criteria, which I think doing that lumping is, again, the issue is what are the risk factors? Doing IV drugs, having unprotected sex, especially anal sex, having sex with people who are HIV positive, having recurrent STDs. If you have a youth in front of you who is checking those boxes, something again to think about to get them at least to the age where they can sort of think a little more maturely about their sexual health. These are just some of the guidelines. The other thing that we don't talk about much, men having sex with men are a significantly higher risk of anal cancer. It's actually not drastically different than cervical cancer before screening. Now, that number goes up significantly if you are HIV positive, but even non-HIV positive, anal receptive men, and you don't see it for reasons unclear to me as much in women, and that may be because we do pap smears and stuff, so we actually catch the HPV other ways. So although Gardasil is recommended for all now, I would just, again, even a stronger push if you have a gay youth, a male coming to you, to really try and make sure this happens. I've had debates with my colleagues about when the recommendations are starting at 9. As the MMR showed you, gay youth actually start even earlier than heterosexuals. So in my opinion, and again, this is a conversation with the patient and the family, if someone clearly is making it very clear to you that they are a gay male, start thinking about vaccinating. Because once they've had exposure, it's a little too late to vaccinate. And the pap smear, there's no reason for you really to do it, but it's exactly the same pap smear, exact same brush, exact same fluid that you do for a cervical pap smear, no different. Something else we don't talk about a whole lot, and that's eating disorders amongst men. Significantly higher likelihood amongst gay men, and young ones at that. It's really, unfortunately, in the culture, a real body image. And for one part of that body image is very interesting. Is one group, it's really the thinner the better, than the other, the bears, the bigger the better. But at this age, it tends to be more being the real thin, small. And then I think the last thing I think I'm going to say about this is also when you're doing your drug screening, be conscious that the gay community, much more methamphetamines, as if the general community doesn't have enough, but significantly more in this community. This is another way of looking at it. San Francisco County actually looked at all the people who actually came in for drug treatment and identified what their drug of choice was. So this is actually a special group. These are people who are admitting that they're having an issue with drugs and want help. The reason why I bring it up, just again to really highlight, if you identify as heterosexual, it was only 8% that came in saying meth was the issue. If you were gay, it was 44% that came in and saying meth was the issue. If you identify as bisexual, it was only 22%. So really significantly more of an issue within this community. We don't need to talk about the badness of meth. I have a feeling you know. If you actually do have a patient in front of you, like, oh my God, where do I start? GLAMO, the Gay Lesbian Medical Association website is really a good source for real quick information, something to download to help answer some of these questions that I just posed. I'm going to talk a little about transgender care, but I want to start with a video.
I feel like it was more about the world around me than it was about me in terms of deciding to change my body. I just got really sick of walking down the street more than anything else. And I got sick of, like, bathrooms. So I got sick of walking down the street and getting like catcalled all the time. And I also like, it was amusing but also irritating that every time I like someone talked to me on the street, they'd call me sir, ma'am, sir. And then I went to see Dr. Rongich. As a baseline, I knew she had experience working with trans folks. She was my boyfriend at the time. She was his provider, and he doesn't like doctors, and he liked her. And I knew a couple other people that saw her, and so she came recommended. My impression was that she had been like trained by another provider, kind of mentored by another provider that was knowledgeable on trans issues, and it seems to be like the only way to really get an education on the issue. But so anyway, that was good background, and then when I saw her, I just felt like she asked the right questions, and she asked them in the right way for me, and I feel like her approach was really supportive, and it was really kind of holistic. Like, she wasn't just asking medical questions, she was asking like sensitive and thoughtful questions about my life and what it'll mean for my life to make this transition. I think she trains her staff really well, and I think I like the way she uses language, and I like, you know, she calls I wouldn't care if she said PAP, you know, but some of her patients might. So she just says like annual exam or your regular exam, and like instead of doing a breast exam, she says she's doing a chest exam, you know. She does things like that, and she also uses like correct anatomical language. But I think she's open to the words that you want her to use, and I think that's really important, and her staff always knows what to call me in the waiting room. But the other experience I've had, and starting with forms, is I went to get a physical at one point for nursing school, and Dr. Rongich was my provider, but I had a broken arm and I couldn't get to her office easily, and it had to be done fast. So I went to just a neighborhood clinic that was covered by my insurance. And the first thing that happened was that, you know, when you're getting a physical, they give you a form to fill out. And they're color-coded, so they have pink forms and they have blue forms. So pink form is for women and blue form is for men. So when I came back with the pink form, again, she's like, oh, you have the wrong form. And I have to explain it to her. My chart is right there, you know, like it's right there. She could look at it. She could look at her computer screen. She doesn't. And she gets really, like, super flustered. It's very clear that she's never knowingly interacted with a trans person. And, you know, they had already set up, because whoever set up the room was just going off my chart and hadn't seen me. They had put a tray to do a PAP, because that was part of the visit. And she got really anxious about the fact that there was a PAP tray in the room, and she was looking at me. And so she started, you know, let me backtrack. So I had explained to her, you know, that I think the way I explained to her is, I'm transgendered. I was born, you know, I was born female. I take testosterone, so I appear male. I haven't had any surgeries, so, you know, that's me. And so she starts talking to me, and she's like trying to figure out if I need a pap smear, and she's just totally flustered. So she starts saying like, well, what do you have? And I'm looking at her like, are you talking about diseases? Are you talking about body parts? Like, what do you mean, what do I have? Like, I'm just sitting here. So she starts saying, like, well, what do you have? Do you have a vagina? Do you have breasts? Do you have a breast and a vagina? Like, what do you have? And it was just so inappropriate. It was so inappropriate. She leaves the room at some point. Nurse practitioner comes in, and she's a hot mess, too. I felt like she didn't want to touch me. Was the feeling I was getting from her. I was supposed to get a PAP that day. First she asked me, do you ever get PAPs? Like, in this accusatory way, which I get a lot, and I think it's totally inappropriate. Like, because number one, it's rude if I do get PAPs and take care of my health in that way, because you're assuming that I'm not. And two, if I did have a hard time receiving that form of healthcare, which some trans people do, asking me in a rude, accusatory way is not going to build my confidence in getting care, which puts my health at risk. My insurance right now doesn't cover Dr. Wrongage, so I've gotten charged like $125. I've seen her twice in the past while because I've been doing some stuff with adjusting my dose and blah blah blah. But sometimes it's just worth it to pay, even when I don't have that money. You know, like I have no idea how I'm going to pay this next bill, but I don't care. Like sometimes it's worth it to just have a payment plan and pay $25 a month for a while to pay off this visit because just the feeling, like the difference in how it feels to be sitting in that room and have her walk in is so, like, it's so huge. And I know that that's true of anyone, like regardless of your gender identity. If you have a trusted relationship with a provider, like that just makes a huge difference no matter what in your care. If you can create what feels like a secure, safe environment, then you're going to have a better relationship, like a more trusted relationship with that patient, and going to be able to make a difference in their health.
I'm going to go quickly through this because we only have 5 minutes. From a male, just so if you want to talk to your patients about it, from a male to a female, a much slower process on hormones. Takes years, actually, really honestly, to get breast development, to get the softer skin, to get the curvature. Hair can be plus or minus. Sometimes the hair becomes more like a female's, more glowing, flowing. Sometimes hair starts to fall out. If you are going to choose to do this, provide hormones for your patients, one of my biggest issues, which is not uncommon, is they'll take what I'm giving, they're unsatisfied, it's not moving fast enough, so they'll get a little bit from their sister, they'll order some from Mexico, they'll get some off the street. And really honestly, that's the only time I actually run into problems is when my patients is taking what I'm prescribing plus others, and that has actually led to some clots. But that is the only time I've actually ever had any problems. Most patients today really, really are not looking for sex reassignment. It doesn't seem to be as important. Most trans women do want breast augmentation though. And some will want facial sort of procedures if they can afford it to have a more feminine look. Trans men, on the other hand, their response to testosterone is much faster. I mean, really honestly, it's amazing. I can start a trans man on testosterone and within 6 months, they are way more hairy than me. They have full beard, hairy arms, like just put me to shame. So you will see really, truly, their transformation happens a lot faster. Most of them, if they actually want surgery, they want top surgery to remove the breast. And usually if I can just get them to bear with me, I can get the periods to stop. If they're spotting, again, that's a reminder that they're in the wrong body. So in some cases, they'll want hysterectomies for that. Phalloplasty isn't as good as creating a vagina, so even fewer of them want complete reconstruction, but we are getting better at it. The real issue is this, and for those of you who can't see well, this kind of lime color is transgender. The real issue is how they feel they are treated by us. So if you look at the questions at the bottom, I will be refused medical care because I am, and the options are LGBT or transgender or living with HIV. Medical personnel will treat me differently because I am. Not enough health professionals adequately trained to take care of people who are. Not enough support groups for people who are. Not enough substance abuse. Community fears, dislikes people like myself. In every single case, transgender community actually felt more negative. I have multiple more slides, and at least from the patient's perspective, we're rude to them, we physically assault them, we manhandle them, etc., etc. So when I say really honestly from my own personal experience, the difficulty is really getting true trust in the community so that you can actually truly work as partners, I mean that. The hormones, if you're at all interested in this, that you can learn in a one CME, quite frankly. I think I'm at my time, so I'm gonna stop. There. This set has several resources in the back, and some of them I tried to pull specifically around youth. So if anyone wants them, I give my permission to whomever to forward this. I have no problem with that whatsoever. Again, I want to thank you all for coming. I think it speaks a lot, just the fact that you're here. So thank you very much. And any questions you have for me.